Thank you for joining the Stark Law Overhaul Series, What's Past is Prologue, Technology Subsidies Part 2. A few housekeeping notes. Presentation materials, including today's PowerPoint and correlating white paper, can be found in the materials box in the upper right of your screen. You may download them at any point during the session. Due to the high volume of attendees, all lines are muted. Our speakers will be monitoring the Q&A box, so please be sure to submit any questions there. The following are a few important items regarding CLE credit for those seeking. Please keep the webinar window open and at the front of your screen. This is especially important for those seeking Kansas, New Jersey, and New York credit, as you will need to enter a code word at some point during the presentation. As mentioned, if you have a Kansas, New Jersey, or New York license, you will be required to enter a code word. During the presentation, a pop-up box will appear. At that time, our presenters will state the code word, and a slide will show what that word is. Please enter it into the box at that time. Again, this is only required for those seeking credit in Kansas, New Jersey, and New York. If you do not require credit in any of these three states, the code word is not required, and you may close the box. Credit for this webinar is being applied for in Arizona, California, Georgia, Illinois, Kansas, Missouri, New Jersey, New York, Texas, and Virginia. Chris, over to you.
Thank you very much, Sue. Greatly appreciated. So as you can see here, we're in the home stretch. Webinar 6 of 7 on the major Stark Law rulemaking from December of last year. These last 3 webinars are covering exceptions. And so what we're presuming at this point, right, is that we've got a physician and he or she has a financial relationship with a DHS entity. And that might be a direct ownership interest, it might be an indirect ownership interest, it might be a direct compensation arrangement, or it might be an indirect compensation arrangement. And the physician wants to refer Medicare beneficiaries to the DHS entity. Well, under those circumstances, that's not permitted unless the financial relationship or the services at issue fit into an exception. 2 weeks ago, we sort of speed dated our way through 7, 8, 9 different exceptions that have been around for a while, but were either liberalized or otherwise tinkered with by CMS in the final rule. Today and 2 weeks from now, we're gonna slow things down considerably, and the focus today is really on just 2 exceptions. The EHR exception, which has been around for a while, but there are a number of things that CMS did with respect to that exception that we're going to talk about today, and my good friend and colleague Rami Fayed is going to take the lead with respect to that. And then we're also going to talk about a very interesting, not completely unrelated, new exception for cybersecurity donations. And Esperance Becton is going to walk us through that new exception and the various conditions that have to be met in order for it to apply. And then, as always, time permitting, and if people have questions, we'll take some questions. So just a little bit of background and context before we dive into these 2 exceptions. So pursuant to the rulemaking, the most recent rulemaking in December of last year, which tacked on several more exceptions, we've now got 40 separate Stark Law exceptions. And if anything, sort of as an aside, if anything signals that you've got an underlying statutory prohibition that is too broad and over-inclusive, it's the fact that you need 40 different exceptions in order to make sure that its policy objectives are met. But that's the hand that we've been dealt, and so for the time being, we'll play it. More than 2/3, so 28 of those exceptions, fall into the compensation arrangement category. So if you have a direct or indirect compensation arrangement, the focus is on these 28 exceptions. As we've talked about in earlier webinars, a number of these compensation arrangement exceptions include a fair market value requirement, or include the fair market value standard, we've called it. And the classic examples are the space rental exception, the equipment rental exception, the employment exception, the personal services exception, of course, the fair market value exception. They all include a requirement that the compensation, often being paid by the DHS entity to the physician, is consistent with fair market value. Now, in theory, you want a fair market value exchange because that helps ensure that none of the remuneration is intended to induce referrals. So if you've got a DHS entity that enters into a services agreement with a physician and pays $200,000, but the fair market value of those services is $150,000, why the government says, what's that extra $50,000 for? Surely, presumptively, it must be in exchange for referrals. Similarly, if you have a physician who's paying a DHS entity too little for office space, for example, the physician's paying $15 per square foot for office space that has a fair market value of $20 per square foot, then the government says, what's that discount for? Surely that discount must be to incentivize or induce referrals. So that's sort of a relatively standard condition in many compensation arrangement exceptions, but there are exceptions to the rule. And there are a number of situations where CMS has decided for one reason or another, you know what, we're not going to require a fair market value exchange between the DHS entity and the physician. Rather, we're going to allow, and in most cases, this is the way the remuneration flows, we're going to allow the DHS entity to provide free or discounted services to the physician. It doesn't have to be a fair market value exchange. And maybe the two most obvious examples are what we commonly refer to as the non-monetary compensation exception. Originally, it had an annual cap of $300 per year. That is CPI adjusted on an annual basis. In calendar year 2021, it's $429 per year. And the theory there is that as long as the remuneration is not cash or cash equivalent, and it's not solicited by the physician, then the DHS entity may provide non-monetary compensation up to $429 per year without receiving anything in exchange from the physician, and fit into that exception. And that covers things like annual holiday parties, de minimis gifts, tchotchkes, whatever it is that might have value and that does therefore create a direct compensation arrangement between the DHS entity and the physician can fit into this exception. Similarly, the medical staff incidental benefits exception, also CPI adjusted. I think the original was $25 per occurrence. It's now $37 per occurrence. And again, provided certain conditions are met and these caps are met, these are exceptions that don't require a fair market value exchange. Here, the logic, of course, is that, look, these are small amounts of money, and in the grand scheme of things, they are unlikely to incentivize a physician to order, for example, a hospital inpatient or outpatient service when he or she otherwise wouldn't. But there are other cases, and we're going to talk about two of them today, where the amounts at issue are not de minimis. We are talking about fairly sizable exchanges of remuneration, again, usually flowing from the DHS entity to the physician, that don't require a fair market value exchange. And here, what CMS is doing is really using, I don't think there's any other way to put it, using the Stark Law as a tool to achieve public policy objectives that, frankly, have nothing whatever to do with the Stark Law's principal policy objectives, which are preventing overutilization, preventing improper patient steering, and preventing unfair competition. They are using this particular law to achieve completely different public policy objectives. And again, we can quibble whether or not that makes sense from a public policy standpoint, whether that's a good way to run a constitutional democracy. But But that's what we have here. And once again, we'll just play the hand that we're dealt. As Rami's going to talk about, the EHR exception dates back to 2006. And one of the policy objectives was, look, people today particularly might forget that 15 or 20 years ago, there was a real question as to whether and how quickly we were going to get physicians and practice groups to move from paper-based records to electronic health records. And it still is not complete, obviously, but it's much improved from 15 or 20 years ago. And certainly one of the reasons why it's much improved is because hospital and health systems and others are able to provide discounted EHR systems to physicians. Absent that exception, it would create real Stark Law issues. Well, we're sort of in a similar place with cybersecurity. This is not a brand new issue, but as recent events, clearly evidence, boy, it's a serious issue. And it's certainly a serious issue in the health industry space. And we are not where we need to be in terms of cybersecurity countermeasures in the healthcare space. And so once again, CMS is using this particular law, which really has nothing to do with cybersecurity, to encourage, stoke the implementation of cybersecurity measures. And because if they don't, it may be difficult to get physicians and physician practices to pony up the funds necessary to make this happen and to make it happen quickly. So that's just a bit of background and context. And so what I'm going to do now is turn it over to Rami, and he's going to be good enough to walk us through the half a dozen or so kind of changes that sanded down and modified the EHR exception a little bit in December of last year. So Rami, the floor is yours.
Thanks, Chris. Good day, everyone. Thanks for joining us here in our penultimate webinar on the revisions and updates to the Stark Law. First up, as Chris just mentioned, is going to be our discussion of the EHR exception. And as Chris noted, occasionally CMS implements regulatory exceptions to achieve a certain policy objective. And in this case, it was to encourage the adoption and implementation of EHR across the spectrum of providers. In 2004, predating here the EHR exception, President Bush had set a goal that every American would have an electronic health record by 2014. And those timeframes kind of aligned themselves with how the EHR exception was originally laid out. And we'll talk about that in a second. But, the idea that in 2004, that within 10 years, everyone was going to have an EHR is akin to, movies that show you what things look like in the future. Things don't always pan out exactly as predicted. Back to the Future showed us on hoverboards and self-lacing shoes in 2015, and that didn't pan out either. But nonetheless, that was the goal, that was the ambition, was to have electronic health records become ubiquitous in this 10-year period from his pronouncement. And in the time period after that initial pronouncement, the HHS had established the Office of the National Coordinator, and there were other initiatives that were put into place to really move this along. But, there's this what's been historically described as the wave that doesn't break, and it's really the slow adoption of EHR by physicians. And so to kind of nudge that process along, CMS in 2016 promulgated a regulatory exception for DHS entities to donate EHR to physicians. And as expected, with most of the things that CMS does in these exceptions, they introduced a whole number of safeguards around the donation to guard against risks of fraud and abuse. So before we get into the changes that Chris just kind of foreshadowed for us, I think it's worth just going over what the exception historically required, just so we have a baseline to understand those changes from. And in general, between 2006 and 2021, the EHR exception provided that non-monetary donations of items and services in the form of software items, information technology and training services could be made provided that the items and services were, number one, non-monetary remuneration that was necessary and used predominantly to create, maintain, transmit, or receive an EHR. So they wanted to make sure, again, that we were narrowly focusing what this donation was about. And then the donation was also limited, that it had to be provided by a DHS entity to a physician. It excluded labs, much to the relief of many labs who frankly did not want to be a potential donor here and have everybody, trying to get them to give donations. So both it worked from a fraud and abuse perspective, as well as something that labs really didn't want. So that wasn't really much of a detriment to them. And that the software had to be interoperable at the time it was provided. And we're going to actually spend a little bit more time on that as we dig into the changes. But bottom line, with interoperable, the idea is to ensure a free flow of information. That's really what we're trying to get at there. Another element here, this requirement number 4 on the slide, that the donor does not take any action to limit use, compatibility, interoperability. In the years since, this has now become more commonly referred to as information blocking. So CMS, even back in 2006, was ahead of the curve. They were essentially thinking about information blocking before it became a thing. And we'll talk more about that in the changes as well. But it really, what that is intended to do is to prevent the donors from tying up the data flow or locking in the data to a particular stream in a way that would somehow restrict or control referrals. So it kind of aligns with those principal policy objectives that Chris had mentioned before, and that it would we don't want to have situations that force providers to refer in one direction or steer patients in a particular pathway. And again, the last item on this slide, at least, is that before you could receive the items or services, the physician has to contribute at least 15% of the donor's cost. And then this has been an important requirement for CMS to do that, in order to make sure that there's skin in the game, really, for the recipient, that you're not just giving things that they otherwise don't need by making them have to contribute and pay a portion of it, that this would be of value to them as well. And the conditions, there are about a dozen of them, keep going here. And in this case, they also made sure that you couldn't, as part of the donation, it couldn't be a quid pro quo where physicians condition their referrals on the donor giving them the technology. You don't want them to say, I won't refer to you unless you make this donation to me. So they didn't want to be held hostage in that way. It prohibited donors from financing or loaning physicians funds for their share of the contribution. Essentially, this prevents an end around the contribution requirement that I just mentioned. And this will come up again. Remember this requirement later. It'll come up sort of at the end of my section here in the slides. And then another requirement is that, as is traditional with many Stark Law exceptions, is that decisions about who received the EHR or how fancy of a system was provided is not in any way determined in a manner that's based on the volume or value of the physician's referrals or other business generated. A traditional safeguard that really flows through many, if not most, of the Stark Law exceptions. As is the next one, which is that the arrangement be in writing, signed by the party, specify the items, list what the donor's cost is going to be, what the recipient's contribution is going to be, essentially just wanting everything out there clearly marked so that it can be reviewable and auditable. And this is another, it's a longer provision here, but that the donor doesn't have actual knowledge of the fact that the physician possesses equivalent items or services. And this, when we talk about our changes, this is really the replacement technology or the replacement EHR provision. They didn't want a situation where every week there was this carousel of EHRs flowing through a physician's office, and next donor comes in, hey, do you want a new EHR? Sure. Do you want a new EHR? And have this constant flow of new EHRs going. If you already had one, then you couldn't make another donation to that entity. There's been changes to that, and we'll get into that in a moment. But let's just make our way through the rest of the laundry list here of requirements from CMS. And you couldn't restrict the EHR's use to particular patients or payer types. So again, in part of the ensuring free flow, ubiquitous use, you didn't want it tailored or specified in any way that would limit its utility. Donors could not provide staffing for physicians' offices. The arrangement couldn't not violate the anti-kickback statute. And the last of the requirements, again, thinking broadly about the timeline here, we're in 2006. The president had a plan that that everyone would have this by 2014. And so CMS said, you know what, we don't think we're going to need this exception forever, so we're going to have it sunset on December 31st of 2013. That kind of aligns with what the world should be at that point. But as we got close to 2013, CMS realized, guess what? We're really not there yet. We haven't actually achieved those goals. The uptake hasn't been as ubiquitous as we thought, and there was a lot of pressure to extend it. And so they said, well, 7 years wasn't good enough the first time. How about we extend it for another 8 years? And they pushed the sunset date to the end of 2021. And again, we'll talk about what's happened with that in the latest final rule. So now that we've kind of talked about what the rule actually required, now we can get into the changes that have been made as a result of the final rule. And the first thing to change is the realization that arbitrarily selecting another sunset date might not be the best way to go about this. So while they originally were thinking, well, how many more years can we kick this can down the road? They realized that there were still many who hadn't adopted EHRs, that there were many new entrants into the market that were coming in who hadn't had an opportunity to have an EHR yet. And CMS was also concerned about potentially losing ground and momentum with EHR adoption and uptake and use in the marketplace if they put another kind of time-limited window before it sunset again. So ultimately, what did they do? They removed the sunset date altogether and made the exception permanent. This gives donors and recipients certainty around the exception's availability to protect their arrangements. So now it will be there for as long as CMS deems it appropriate. So that's the first change that we are faced with here in the rule. The next thing that CMS did was clarify certain scope issues with respect to the rule. And the first one here is related to donations of cybersecurity software and services. And this is separate from the discussion that Esperance will take us through in a bit, but it is related, and we'll talk about that now. The concern really was, as EHRs have evolved and developed over the years, the cybersecurity threats have become ever present and very, very serious. And so a question arose, well, if does the EHR exception itself permit, as part of the items and services that I donate, can I include cybersecurity software and services? And people would scratch their head and they'd go back and they'd look at the definition in terms of what the exception would allow. And they were unclear as to whether the phraseology of necessary and used predominantly to create, maintain, transmit, or receive an EHR fit cybersecurity software and services into that. And so for the most part, what many providers or donors did is they would require the recipient to, they would provide that, but they would make the recipient pay 100% of the cost related to that service, which frankly also ended up resulting in dampening of the uptake of EHRs to begin with, because on top of the 15%, you ended up having to pay 100% of the costs associated with this. And obviously, this isn't a great result. We want to make sure the adoption of EHR is there, and we want to make sure that the technology is protected from the ever-present intrusions and actors out there that are looking to gain access to that in an impermissible way. So to avoid any further confusion or debate on this point, CMS first says, guess what, guys? It's been allowed all along, but we understand that it wasn't 100% clear. So in the final rule, you can see there on the slide, they have now explicitly added that amongst the items and services that may be provided are cybersecurity software and services, which are, and then you can see they also added to protect electronic health records. So now it's pretty clear that this is part and parcel of the exception. It is permitted. Again, this is separate from the cybersecurity exception that Esperance will discuss, but they use the same definition for cybersecurity for both exceptions, except that the one that Esperance will discuss is a broader exception. The one here under the EHR exception is narrower in the sense that when you provide the cybersecurity software and services, it must still satisfy that requirement that it be necessary and predominantly to protect the EHR. So you still have that restriction, and you have still here the recipient cost sharing requirements, that 15% requirement. So you can bundle it in, but unlike before where maybe they were paying 100%, you only have to pay 15%, but you still have to pay something if you're the recipient. The next change is on the concept of replacement technology. And as you may recall, when I was laying out the requirements, historically, the EHR exception specifically had a condition that the donor could not have actual knowledge or act in reckless disregard of the fact that the physician already possessed an equivalent EHR that would be provided by the donor. And as part of this rulemaking cycle, CMS acknowledged that even if a provider's existing EHR meets the current certification requirements and wasn't really a risk to patients, that there still could be legitimate business and clinical reasons for replacing a provider system. And that there are times when a provider needs to replace an existing technology because it hasn't lived up to its particular promise or marketing materials, or just wasn't really a good fit for a particular provider. But the replacement is nonetheless a prohibitively expensive undertaking for a physician, which essentially locked them into that poorly operating, poorly functioning, not well adapted EHR for them. So one of the principles we discussed earlier was CMS being concerned with providers being locked into a technology or being subject to some type of data lock-in. Well, the idea that CMS would then preclude a provider from being able to replace a technology that was a poor fit for them was anathema to that stated goal and objective. So all this to say that CMS has a change of heart and says, you know what, replacement EHR would be permitted and could fit within the construct of the EHR exception. And part of its rationale for reaching that conclusion is that the replacement EHR would be subject to the exact same requirements of the exception as an initial donation would be, and that the recipient contribution component would help guard against replacement for the sake of replacement. They believe that this would strike that appropriate balance between making the replacement financially feasible, but still having safeguards to protect the Medicare program and Medicare beneficiaries from potential fraud and abuse. So that's our next change here, is that now we have the option to change our software if and when it becomes necessary. The next change we're going to discuss, we'll discuss it actually in two parts, really, two discrete parts, just to keep it clear and simple. First, CMS revised the definition of what it means for a technology to be interoperable. And it did so by applying the definition from the Cures Act, which was passed subsequent to when the original EHR exception came into play. And the new definition, and if you go back to the proposed rule, actually had three parts to the definition, but ultimately in the final rule, CMS only included two parts to the definition, and we'll talk about that. Part one, as you can see on the slide in the final rule piece, is for it to be interoperable. It had to be able to securely exchange data and use data from other technology. And in the proposed rule, they had also added in a requirement that it be, without special effort on the part of the user, but they ultimately decided that we didn't need this kind of last part because it might impose unnecessary certification or requirements around that. So they just said, you know what, we just want to make sure that it can securely exchange data with other health information systems. We want it to be able to free flow of data between and amongst them. And the second part is that they wanted to make sure that in order for something to be interoperable, you have to have complete access exchange and use for all health information for authorized uses under state and federal law. And with those two components of the definition, that's been designed to align with the terminology as used in the Cures Act. They feel that we now have a much more streamlined definition of interoperable that also aligns with definitions being used by other agencies that are working on evolution and similar development as it relates to how these types of systems are going to communicate with each other and issues around information blocking, which we'll talk about in a second. The third part that didn't make it into the final rule would have also required that for the technology to be interoperable, that it didn't constitute information blocking. But because there were more recent authorities out there from ONC and that they were already laser focused on addressing what information blocking would be, what would constitute information blocking, what wouldn't constitute information blocking, CMS decided not to dabble in the concept at all. And it just took the cleaner approach of saying, you know what, we're just going to leave it out of here. You're going to have to do those other things anyway as it relates to those other authorities. So we don't need to get into the middle of it. And so they just kind of left that out of the final rule. The second part of their modernization effort of interoperability relates to the deeming provision within the definition. And historically, the EHR exception provided that for software to be deemed interoperable, it had to be on the date that it is provided to the physician, to have been certified by a certifying body authorized by the National Coordinator for Health Information Technology. And so the first change that CMS made, and it's hard to spot on the slide, but you'll see that the word is there. So what they changed is that it used to say it has been certified, and now it has to say it is certified. And it doesn't look like a big change, but why make the change at all? Well, the concern was that as originally drafted, that as long as the technology had been certified at some point in time, then it could meet the definition of being interoperable. And that would be akin to buying something today that was made in the 1950s and had a label on it that said, state of the art. Well, it may have been true that it was state of the art when they slapped that label on in the 50s, but if I were buying it today, it's highly unlikely that that item would be state of the art today. And they were concerned the same thing might happen with an EHR. They didn't want just the technology to have been certified at some point in time. They wanted the technology being donated to have a current and active certification at the time it is donated. So a minor word change, but it's an important one nonetheless. The second change, I think, is probably the more important of the two, really responds to commenters who asked whether a certificate from one of these certifying bodies approved by the National Coordinator was the only way to establish that an EHR is interoperable. And CMS clarified that the requirement in the exception simply requires that the EHR be interoperable. We didn't say or prescribe the method for determining interoperability. And really what that means is that parties are able, if they want to, take advantage of the deeming provision by having an EHR with a valid certificate that's from an approved certifying body, but it's not required in order for you to meet the requirements or conditions of this particular exception. So if you have another way to establish that the EHR is interoperable, then you could rely on that as your basis for satisfying the exception. Whether people will take that pathway or not, or whether they'll just take the more certain pathway of one that's has that certificate, to be seen, because most people don't like to take chances with, whether they are or not going to meet a Stark law exception. So I understand what they've done here in terms of trying to increase flexibility around the deeming provision, but unclear still how that will play out in the marketplace, especially when you're dealing with something like the Stark law, which is not intent-based, and you either meet an exception or you don't. So I would take the guidance here with a grain of salt. Next on our list, I told you I would mention information blocking, and here you go. I'm not a liar. A few more comments on information blocking. Separate and apart from the definition of interoperable, which we just talked about, remember that the EHR exception, even though it didn't actually use the term information blocking in the historical version, there was that condition that we had talked about that said that the donor not take any action to limit the use, compatibility, or interoperability of the EHR. And CMS had included that condition to ensure, again, the free flow of information, and that prevent donors from really locking in the data through their donation and or locking up referrals from physicians. So this concept, as a result of the Cures Act, is what we now call information blocking. And in the proposed rule, CMS thought it was going to just update the information blocking prohibition to align with the more recent legislation and guidance on that as a result of the Cure Act. But after looking at it and considering it in the final rule, they figured that they would just leave it to the other agencies handling this issue, is or isn't information blocking, and that under those regulatory structures, providers would face the necessary regulatory scrutiny, the enforcement, and penalties without CMS, again, having to get in the middle. And so what did they do? They just surgically removed this requirement from the final rule. Again, part of the reduction in the overall number of conditions from 12 to 8. This is one of those reductions, and relying on sister agencies to guide us and lead the issues around information blocking without getting it kind of mired here in a Stark law exception. The last of the changes that I think are worth discussing in this particular changes to the EHR exception relate to the recipient contribution requirement. And CMS considers the recipient contribution requirement to be an important safeguard to address the program integrity risks associated with EHR donations. That said, many stakeholders believe that recipient contribution requirements were still stifling more widespread adoption of EHRs. And CMS, in response to those requests, threw out two options in the proposed rule. Under option 1, CMS would reduce or eliminate the required contribution amount for small or rural physician organizations. And as part of that request, they said, well, can you also give us some input on how we should define small or rural organizations, rural physician organizations? Under option 2, they would just eliminate the cost sharing requirement altogether. And with this option, CMS said, if we do that, tell us what you think about how this is going to impact the use and adoption of EHR technology, and also what this means for our big program integrity concern. So, and in addition to these two alternatives, CMS also asked for input on whether they should modify or eliminate the contribution requirements for updates to previously donated EHR. So separate from the replacement technology, we're talking about updates to an existing technology. And historically, updates would be subject to the same type of contribution requirement here. And they asked, whether that made sense or not. So which option did CMS ultimately pick here in the final rule? If you guessed option 1, I'm sorry to say you'd be wrong. But if you guessed option 2, well, you'd be wrong too. Because in the final rule, CMS chose the previously unknown door number 3. And in that, it said, you know what, we thought about it, we threw out these options, but the better option is really for us to retain the cost sharing requirement for initial donations and for donations of replacement technology. And we're not even going to monkey with the percentage. We're going to keep it at 15% a minimum as it has been before. So essentially, they threw out the possibility of wanting or willing to make changes, but just could not pull the trigger on it. This is just one of these key safeguards that they believe belong in the rule. It's one of the few that they felt from a program integrity perspective was just critical to them, and especially with now permitting replacement technology to be something that could be donated, it was just too much of a change for them to now also change the contribution requirement. On the separate issue of the contribution requirement related to updates to previously donated EHR, CMS takes a bit of a puzzling approach in my view, in that it says, you know what, we're going to permit physicians to pay their contribution amount at reasonable intervals. So, you know, of course you read that and you start going through the rule looking for, okay, tell me how am I going to define what's a reasonable interval? Well, surprisingly, actually, CMS leaves it completely undefined. And the trouble with that is that with the supposed flexibility now that the exception, the EHR exception still has that requirement, if you remember way back from the early slides, that donors not finance or loan physicians money in connection with the items and services that are being donated. So to me, at least, it's unclear how you're supposed to reconcile this supposed flexibility with the existing condition. Allowing physicians to pay their required contribution for updates at reasonable intervals sounds, at least arguably, like financing or loaning funds to the physician. No real clear answer on this point, and it's just important to consider exactly how you would navigate these seemingly incongruent messages from CMS. So it's in there. It says that with respect to updates, they can pay it at reasonable intervals, but you still have to remember that there's that prohibition on loaning and financing. So, you know, good luck trying to sort through that one. We've covered a lot of ground here, so I thought just to quickly sum them all up, we've eliminated the sunset date. It's now a permanent exception. Cybersecurity, software and services fit within the things that can be donated as part of the EHR exception. Replacement technology is now permitted as a permissible donation. We've modernized the interoperability definition to align with the Cures Act. We've explained the clarity or clarification on the deeming provision as not being required. It's just an option. We've taken out the term information blocking. You've got to go to information blocking rules by ONC to figure out what you can and can't do in that regard. And contribution requirement is here to stay. Those are the big changes in the EHR exception. And before I turn things over to Esperance, I do have an important announcement for attendees seeking CLE credit in Kansas, New Jersey, or New York. Please write the code word in the pop-up box that appears on your screen. The word is Prologue. And if you don't have a license in any of those states, you don't have to worry about this step. This is only for Kansas, New York, and New Jersey. And with that, I am going to turn things over to Esperance. At least I think I'm turning.
Thank you, Rami. Good morning and good afternoon to all. Thank you for joining us. And as Rami stated, I will be discussing the newly created cybersecurity exception. Just to provide a little bit of background, and as Rami and Chris have essentially articulated pretty clearly, before 2021, there was just no Stark Law exception for donations of cybersecurity technology and related services. After numerous comments and suggestions, CMS finally proposed and finalized this new cybersecurity exception. One of CMS's main concerns when it proposed this exception, driving force behind the push for its creation was the concern that while the risks of cyber attacks often reside as certain weak links in the technology systems or chains, these risks have an even greater impact. Cyber attacks in the healthcare ecosystem impose high costs on the healthcare industry. They cause improper disclosures of protected health information, and more importantly, they can cause grave danger to patients. In creating this exception, CMS was under the expectation that donors and recipients often would be part of the same sort of integrated system, such as a hospital and a physician using a shared interface. And as a result, donors would be providing technology and related services in an effort to protect both the recipients and the donors themselves from cyber attacks. When it proposed the new exception, CMS's goal was to help improve the cybersecurity posture of the healthcare industry. The exception would remove essentially a perceived barrier to donations and address the growing threat of cyber attacks that infiltrate healthcare data systems and other information that is essential to the delivery of healthcare. And also, CMS attempted to strike a balance between the government's policy aims and the risks of Medicare program abuse, which can arise when DHS entities are permitted to provide expensive items and services to referral sources. So as we proceed through this presentation, you will notice that the cybersecurity exception, as finalized, does bear some similarities to the EHR exception that Rami discussed, but this cybersecurity exception is quite broad in terms of the scope of protected cybersecurity technology and related services. However, CMS does attempt to institute a few limitations in the form of conditions, including, as I will discuss more later, the requirement that the cybersecurity technology and related services be necessary and used predominantly to implement, maintain, or reestablish cybersecurity. In the proposed rule, CMS offered these new regulatory definitions for both cybersecurity and technology. These definitions were intended to be as broad as possible to promote the adoption of cybersecurity measures. For the definition of cybersecurity, CMS essentially just pulled the definition from the National Institute for Standards and Technology Framework for Improving Critical Infrastructure. That said, CMS did request comment on whether this definition was actually sufficiently tailored to the healthcare industry. Now, as far as the definition of technology, CMS proposed to define technology as any software or other types of information technology other than hardware. CMS proposed excluding donations of hardware because it thought, well, hardware was often too expensive and can sometimes be used for purposes other than cybersecurity. And in essence, CMS feared that permitting donations of hardware would also increase the risk that the donations were being made to influence referrals. So in an effort to sort of meet in the middle or consider alternative solutions to address these concerns, CMS solicited comments on two alternative approaches. One, it would permit the donation of hardware that exclusively served cybersecurity purposes, or alternative two would be to permit the donation of hardware if it was determined to be necessary as a direct result of donor or recipient specific cybersecurity risk assessments. And in addition to the two proposed definitions, the proposed cybersecurity exception included 4 requirements, a couple of which are pretty standard and often found in other Stark Law exceptions. So first is what we are calling the necessary and used predominantly requirement. This means the exception would apply only to technology and services that are necessary and used predominantly to implement, maintain, or reestablish cybersecurity. The second is the traditional safeguard and Stark Law exceptions, the volume and value standard. The donation of technology in this instance the donation of technology or services, in this instance, could not be determined in a manner that takes into account the volume or value of referrals or other business generated between the parties. And third, we have it could not be conditional. So neither the physician nor the physician's practice could make the donations of technology or services a condition of doing business with the donor. And finally, we have the fourth is the documentation requirement, which sort of speaks for itself. The arrangement just has to be documented in a writing. Now, CMS requested comments on several aspects of these requirements. And first, the agency wondered whether it should create deeming provisions. One deeming provision proposed could be that parties could use, it could be a deeming provision that parties could use to establish that certain arrangements would be deemed to satisfy the necessary and used predominantly requirement, for example, by conforming to a widely recognized cybersecurity framework. Or another could be a deeming provision for the volume or value standard, which could consist of a list of recipient selection criteria that, if met, would result in the arrangement being deemed not to take into account the volume or value of referrals or other business generated by the physician. CMS requested some additional comments on other issues, including whether it should restrict the types of entities that could be donors, whether to require a minimum contribution to the cost of the donation from the recipient, and it even considered whether to specify the terms for a writing that documents the donation arrangement itself. Well, in the final rule, CMS ultimately adopted the cybersecurity exception essentially as it proposed, with only one substantive exception or modification. CMS ultimately removed the other than hardware language from the definition of technology. This ultimately removed what would have been a ban on donations of hardware. In the final rule, CMS seemed to come to a realization that a ban on hardware would just be way too difficult. CMS noted that the lines between hardware, software, and other technology can be blurred, and quite frequently, multiple components of technology are packaged together as a bundle, which would make it difficult to make separate donations. These considerations ultimately resulted in this very broad definition of technology. A few clarifications CMS added. Despite adopting this broad interpretation of technology, CMS emphasized that the definition of technology here is specific and applicable only to the cybersecurity exception, and it's not intended to affect the meaning of the term information technology used in other regulations or the term technology as it appears in the EHR exception. And although CMS did not ultimately adopt either proposed alternatives to the hardware ban, the agency emphasized that parties are definitely encouraged to continue to perform risk assessments to determine those donor and recipient vulnerabilities to cyber attacks and to assist in creating their own cybersecurity programs as they see fit. And so now that we've sort of covered that one substantive modification about the hardware ban, let's take a look at what CMS ultimately deviated from and why. CMS decided not to establish, let me make sure that okay, here we are. So CMS decided not to establish any deeming provisions in the cybersecurity exception because of its concern for two things. One, it concluded that the level of specificity that would be required for the provisions to be triggered could result in confusion. And the second, the provisions could be interpreted as prescriptive requirements that would prevent parties from making beneficial cybersecurity improvements. This would be particularly true here, where the healthcare industry is not only grappling with a new exception, but said exception must now be applied to emerging and rapidly evolving arrangements in technology. CMS figured this could be too daunting of a task and, quite frankly, confusing. So CMS also rejected several other proposed changes that it made to the definition of cybersecurity, including those that would have expressly included all data analytics and reporting functionality, those that would have covered processes such as identifying or recovering from cyber attacks. And it also rejected those that would have limited the definition to only effective cybersecurity or cybersecurity measures that are designed to protect only a particular subject. CMS then also declined to establish a specific requirement for documenting the donation arrangement as it had proposed. But it did acknowledge, however, that documentation in the form of a signed agreement would be essentially the best practice. CMS further articulated its rationale for adopting a broad cybersecurity exception in its responses to commenters. For example, some commenters were concerned that the cybersecurity exception could have anti-competitive effects or could limit physician autonomy because large healthcare entities could offer larger donations. And some even thought that it could even result in inappropriate information blocking, as Rami discussed earlier, as some providers cite cybersecurity as a reason for not sharing data or providing data access to physicians. CMS nonetheless disagreed and rejected these concerns, stating instead that many donors will actually make cybersecurity donations more likely as a self-protective measure, so the exception will not pose the risk of program or patient abuse. Another commenter proposed, which actually elicited quite a long exchange with CMS in the comments, proposed that the adoption of alternatives to the necessary and predominantly terminology, such as requiring the technology or services to have a clear nexus to cybersecurity, or maybe to suggest or say to substantially further the interests of strengthening technology, rather than saying necessary and predominantly. This commenter explained that the cybersecurity technology should be necessary for the provision of the services involved, such as a hospital donating cybersecurity technology to a physician to ensure the secure transfer of personal health information and improve care coordination for shared patients. The commenter insisted that the cybersecurity exception should not protect donations that are used as a way to entice new business. And again, CMS pushed back and concluded that the necessary and used predominantly language does delineate the scope of the exception and will ensure the donations are made to address legitimate cybersecurity needs of donors and recipients. And this is kind of just as a footnote, CMS also mentioned that although it is not adopting the clear nexus standard that the commenter suggested, it does question whether donated technology or services would be necessary for the donor or recipient to implement, maintain, or reestablish cybersecurity if the technology or services themselves are not connected to the underlying services furnished by either party. So in essence, CMS's response seems to suggest that in its view, the clear nexus is sort of underlying in the necessary requirement. So now in this final slide, you will find the full text of the cybersecurity exception as finalized. In essence, and to conclude, the new cybersecurity exception provides an exception for non-monetary remuneration consisting of technology and services that are necessary and used predominantly to implement, maintain, or reestablish cybersecurity when all of the additional conditions are also met, which is sort of similar language to what is found in the EHR exception. And the conditions that are instituted and finalized here, as I've discussed, the first is the volume or value standard, which is pretty traditional. And the second is neither the physician nor the physician's practice may make the receipt of technology or services or the amount or nature of the technology or services a condition of doing business with the donor. And then finally, the third is the documentation requirement. So that essentially concludes our discussion of the cybersecurity exception. And again, thank you for pushing along with us. Chris, I will turn it back to you for some Q&A.
Great. Thank you very much, Esperance. And I'm just going to pop back to your last slide for a minute, because one of the sort of interesting, if fairly obvious, points when you juxtapose the EHR exception and the new cybersecurity exception is there's a bunch of lessons learned here. And CMS really isn't going to play any games this time. As Rami mentioned, the 2006 EHR exception had 12 conditions. They managed to skinny that down to 8 in the final rule. And it also had and continues to have a contribution requirement. Well, this final text of the cybersecurity exception bears little resemblance in terms of length or complexity to its sister EHR exception. And as Esperance, went through, CMS was not really having any of the commenters' suggestions that this thing be cluttered up and littered with additional conditions or requirements. This is about as simple as it gets. Hardware's in, there's no contribution requirement, and as long as you meet these 3 requirements, donations of cybersecurity measures can be made to physicians. And that's a long way off from where they began in 2006 when they dipped their toes in the water of permitting donations of what can be fairly expensive systems. So I think the clear message here is that CMS would like to get real state-of-the-art cybersecurity measures in place across the healthcare industry much more quickly than we managed to effectuate the introduction and implementation of electronic health records. Time will tell. So thank you, Esperance. Terrific job. We don't have any questions, so in addition to you and Rami being much more concise than Gadi and I ever can be, we've come in on time. We don't have questions. The only thing I think I'll mention then in passing is we've got one more to go, 2 weeks from now, when we will be talking about some very interesting, brand new value-based exceptions that have worked their way into the CMS jurisprudence with respect to the Stark Law, and also HHS OIG jurisprudence with respect to the anti-kickback statute. And we'll go through those methodically 2 weeks from now, and then we'll be done. So thanks again for joining us. Everyone have a wonderful, long and restful Memorial Day weekend, and hopefully we'll see a lot of you back here 2 weeks from now. Thanks again.